as a discussion forum for dentists to discuss fluoridation, and they actually have an incredibly wonderful website if you're into the science of it. Please welcome Dr. Stan Litras.
Well, I have to apologise because I've got the flu. Serves me right for not having a vaccination, I guess. I had to get myself out of my sick bed and drive 8 hours to be here, but I'm glad to be here. I haven't been to Thames before, and I think it's a very cool town. Your upcoming referendum will be your chance to make an even better town by making your tap water healthy to drink and cook with. When I left Otago Dental School in the 1980s, I believed that fluoride was a marvellous thing for keeping teeth healthy, but when I was taught very little about the science at that stage and even less about the toxicity. Questioning fluoridation was frowned upon, actually. It was only a couple of years ago when a colleague challenged me to look at the research rather than just giving it uninformed support that I quickly changed my mind about water fluoridation, because I considered, first of all, the evidence that it works was poor. Secondly, the evidence that it causes harm is concerning. And thirdly, I didn't think the public were being properly informed. The Health Department policy says the Ministry of Health strongly supports water fluoridation as an effective, safe and affordable public health measure to improve oral health. It's the DHB's job to enforce this policy at the community level. They make statements like this to its city councils and the general public. They say that it reduces tooth decay in 5-year-olds by 40%. They say that if you stop fluoridating a community, the decay rates will explode. They say that water fluoridation benefits everybody, regardless of your diet or how well you clean your teeth or whether you have teeth or dentures. They say that water fluoridation especially helps Maori and low socioeconomic groups. They say that no one is harmed in any way by water fluoridation. And they say that dental fluorosis is just a cosmetic effect and it actually looks quite nice. And they say that it's cheap. It's all on their website. I disagree. I believe these statements are misleading and are not backed by reliable evidence. Health authorities in the few countries which deliberately add fluoride to water supplies influence public opinion with misinformation campaigns like this one, the campaign by the Queensland Health in 2007, trying to frighten people into mandatory water fluoridation. And you may have seen similar images here. I saw them in Hamilton. So the picture on the left is supposed to be what the teeth look like in areas which have water fluoridation. Those in the middle are supposed to be what happens if you don't have water fluoridation. And then for good measure, a disturbing picture of a young child having its rotten teeth yanked out under a general anaesthetic. The problem I have with this is that this condition is known as nursing bottle syndrome or early childhood caries. And it's caused by the child sucking on sweetened drinks throughout the day. It has nothing to do with water fluoridation, and it occurs just as much in fluoridated areas where caregivers are either poorly educated or neglectful. It is not clear to me whether such campaigns are a deliberate attempt to mislead the public or whether the health department is itself subject to poor advice.
We know full well that I myself, for example, provided it were properly boiled, could drink many litres of the ready-to-use 2,4,5-T spray each day, and it would not affect my health.
So you would drink it?
I'm perfectly prepared to drink it.
So public health authorities have been mistaken in the past. Now I believe the same flawed policy making is driving the misguided practice of community water fluoridation. Let's look at the facts. Everyone, including the Centre for Disease Control, which is the main proponent of water fluoridation from the 1940s, agrees by now that the primary mechanism by which fluoride delays decay, I say delays, not prevents, is topical, not systemic. That is, it works directly on the tooth in the mouth. Swallowing fluoride is pointless. Of course, this means that the whole rationale for swallowing fluoride had been wrong for 50 years, and the research used to justify it was misinterpreted. In fact, the only effect of swallowing fluoride is damage to the tooth-forming process, resulting in an increase in dental fluorosis. But hey, it seems you can still be classed as one of the top 10 public health achievements, even if your theory is shot to ribbons. Tooth decay is not caused by lack of fluoride. It occurs because bacterial plaque on the tooth surface can break down sugars to produce acids which diffuse from the plaque into the underlying enamel and break down the tooth structure, dissolving out phosphate and calcium. The outflow of these elements can be reversed or slowed down under favourable conditions in the plaque or biofilm. These include a concentration of ions such as calcium, magnesium and fluoride. However, this does not occur from water fluoridation. The amount of fluoride is too low to be of any benefit, as the CDC themselves conceded 25 years ago. What's more, if kids do not brush their teeth, the plaque will generally be too thick. Oops. Sorry, I'm sick. The plaque will generally be too thick for the fluoride ions to penetrate, so fluoride will not reach the enamel surface. Thus, water fluoridation is not a substitute for toothbrushing. If the kids aren't brushing, the fluoride won't get through. If they are brushing, why do they need fluoridated water? Fluoride can slow down decay if there is an early lesion already present, if there's a bit of plaque on the tooth, but not too much, and if the high-strength fluoride toothpaste or mouth rinse has delivered a high enough concentration of fluoride ions directly into the mouth. The internationally regarded gold standard in health science review bodies, the Cochrane collaboration, just this year completed its first ever review on water fluoridation efficacy. Harm to health was not in its scope apart from dental fluorosis effects. The Cochrane group follows strict protocols to avoid bias in their assessments, to be transparent and inclusive, and they do not accept funding from corporate interests. They aim to give the best advice for policymakers and the public. Perhaps unsurprisingly, their conclusions did not echo those of the 2014 New Zealand Royal Society review. The Cochrane review concludes that there is insufficient reliable evidence to support claims that fluoride helps address disparities with underprivileged groups. Also, there is insufficient evidence that decay increases when a community stops fluoridating, and also there is insufficient evidence that it has any benefit in adults. It also found that in areas fluoridated at 0.7 parts per million, which is less than Thames, dental fluorosis occurs in 40% of people, 12% of which is of cosmetic concern. Though we're not confident about the amount of tooth decay reduction in today's communities, as most of the data used in their calculations was from before the advent of fluoride toothpaste and other sources of topical fluoride which we have today. It's been available since the early 80s. The included studies are shown here. with the majority of them from the 1950s and 1960s and going back to the 1940s. The graph on the right gives an indication of how much greater the decay rates were during that time, and why the inclusion of that old data bloats out the calculation considerably. So what does the real life data show? Do we see any benefit in areas with water fluoridation? We find that decay rates have dropped equally in countries which do not fluoridate water, which would be the vast majority of countries, and 97% of Europe. This graph shows that the lowest decay rates are actually seen in countries with no fluoridation whatsoever. The proportion of water fluoridation is shown in purple. New Zealand's down the bottom there. The least decay rate is Denmark with no water or salt fluoridation. Some countries use a bit of salt fluoridation. The size of those bars indicate what proportion of the population has it. The New Zealand school data also show no significant difference between fluoridated and unfluoridated 5-year-olds and year 8s. On the 2011 data, if you were to extrapolate that, the difference equates to saving 1 filling every 30 years. The latest data, extracted painfully under the Official Information Act, this shows no reduction in the proportion of cavities in Maori and Pacific Islanders living in areas of Auckland with fluoridated water supplies over those who don't. In fact, those with the most rotten teeth are in the fluoridated communities. If I can just explain that, the axis down the bottom shows the number of fillings in a child from 0, that's kids with no decay on the far left of those graphs, one being 5-year-olds and one being 12 to 13-year-olds, and way up to 15 fillings. So the orange ones are the fluoridated kids, and the little orange bars right on the right, the kids that have 10, 11, 12, 15 fillings, most of those are orange, they're fluoridated kids. So the target groups that you're looking at is the small proportion of children from about 4 or 5 fillings upwards. And overall, there are just as many of those in fluoridated areas. We're seeing the same picture in other areas of the country, such as Taranaki, although the DHBs in some areas are refusing to supply the information, even under Official Information Act request, for privacy reasons. DHBs warn us about an explosion of child general anaesthetic extractions if fluoridation is stopped, and they emotionally blackmail councils to implement their policy. In Nelson this year, the DHB dentist presented a jar full of extracted teeth from a 4-year-old child to the councillors and claimed it would only be half full if they fluoridated their water. Nelson's never had fluoridation, and they've got one of the best decay rates in the country. No evidence is ever presented to support such DHB claims, yet evidence which refutes it is kept hidden. This is concerning. Let's look at your local region, Waikato. 2013 figures show no significant differences in the numbers of decay-free children. In fact, the curves are remarkably similar, with, if anything, unfluoridated 5-year-old children having consistently less decay incidence than fluoridated. And year 8's also showing no significant difference. Data on United States children also show no benefit from water fluoridation. There's absolutely no difference in the decay rates of fluoridated, non-fluoridated children at all age levels up to age 17. The Iowa University study has followed 600 children from birth until their teens, carefully controlling fluoride intake from all sources. It has found that swallowing fluoride does not reduce tooth decay, but is strongly related to dental fluorosis. It did find that tooth decay reduces the more that you brush. Now there's a novel idea. Fluoridation promoters quote the 2009 New Zealand Oral Health Survey to justify their claims that water fluoridation results in up to 40% reduction in tooth decay in children. Note, however, the lifetime saving found in this survey is only 12%, or 2.5 fillings. However, all that aside, the 2009 New Zealand Oral Health Survey was not designed as a scientific study into fluoridation, so it is inappropriate to quote it in advising health policy. Besides its small sample sizes, there was no control for numerous factors which could affect findings. And it spells it out in several parts of the document that it was not a scientific study on fluoridation. Some of the confounding factors which can affect the findings are shown here. The differences between rural areas tend to be the ones which are unfluoridated. However, rural areas are also related to higher decay rates. They tend to have a higher proportion of Maori who tend to have a higher decay rate, various reasons. Lower socioeconomic, less access to care, which is important. Comparisons by age can be misleading. Fluoridation can delay tooth eruption, which affects cross-sectional age comparisons. Migration from fluoridated to non-fluoridated areas and vice versa. Toothbrushing frequency and type of toothpaste, whatever. Water consumption, you might be in a fluoridated area, but you might not be drinking tap water. The diet, beverage, sugar content, social factors, geographical factors, fluoride supplement use, fluoride tablets, education, particularly parental education, antibiotics in processed food. And this is quite important, I think, is the bias that you get in recording how much decay there actually is in various children, the processing of the data, and publication bias. So in summary, global, international, national and local data show no benefit from water fluoridation in modern society. Research used in the past to support water fluoridation was flawed and unreliable. Modern understanding of the mechanism of action of fluoride makes it very unlikely that swallowing fluoride is of any benefit at all. I will speak a bit later on about the health issues. Thank you.